So, in this lecture, we will be covering about the World Health Organization perspective of palliative care. It has been prepared by myself, Dr. Piyush Gupta. I am Secretary of Cancer Aid Society and National Association of Palliative Care for Ayush and Integrative Medicine. WHO definition of palliative care was introduced in 1990 and 2018. Palliative care is an important approach that improves the quality of life of the patients, adults and children and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through the early identification, correct assessment and treatment of pain and other problems, whether physical, psychosocial or spiritual. So, there have been various international conventions and resolutions mentioning about palliative care. World Health Assembly 2014 under resolution 67.19, it talked about strengthening of palliative care as a component of comprehensive care throughout the life course in Geneva. In 2014, the first ever global resolution on palliative care, WHO called upon WHO and member states to improve access to palliative care as a core component of health systems with an emphasis on primary health care and community as well as home based care. In the WHO Global Action Plan for Prevention and Control of Non-Communicable Diseases 2013 and subsequently revised in 2020, palliative care is explicitly recognized as part of comprehensive services required for the non-communicable diseases. In 2018 Astana Declaration on Primary Health Care. The Global Conference on Primary Health Care took place in October 2018 in Astana, Kazakhstan, co-hosted by WHO, UNICEF and Government of Kazakhstan. The Declaration of Astana chart course to achieve universal health coverage. 40 years since Declaration on Primary Health Care in Alma-Ata, palliative care is part of universal health coverage for all. Countries have reaffirmed the role of primary health centers in this declaration. Organization of American States, Inter-American Convention on 1.1 protecting the human rights of older persons held at Washington DC, and there was a convention in 2014 at UN transforming our world, the 2030 agenda for sustainable development. The 2030 agenda slogan leave no one behind means that governments trying to achieve sustainable development, goal number 3 must develop palliative care policies to cover the 40 million persons, a total that includes at least 20 million carers who require palliative care support globally. Currently, fewer than 10% of the patients who need palliative care in low and middle income countries receive it. UN 2016 Chapter 2 of the outcome document of the United Nations General Assembly special session on world drug problem also talks about availability of essential narcotic drugs for treatment of pain. Again we had in 2019 a political declaration on universal health coverage at New York. Then in 2020 there was a resolution for promoting awareness, raising education and training as part of the comprehensive approach to ensure access to and the availability of controlled substances for medical and scientific purposes and improving their rational use. This was from the Commission of Narcotic Drugs, and World Health Assembly 2020 COVID-19 response resolution also talked about palliative care. National Cancer Control Programs, Policies and Managerial Guidelines. It talks about palliative care, where they say that symptoms not only influence the quality of life, but they also influence the course of the disease. Remember, pain can kill and so can depression. Why palliative care? To help family cope during the patient's life and may also positively influence the illness as well as bereavement. It enhances the quality of life throughout the course of illness. It is applicable early in the course of illness together with the treatment. According to World Health Organization, palliative care provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process, intends neither to hasten nor to postpone death, integrates the psychological and spiritual aspects of patient's care, offers a support system to help patients live as actively as possible until death. Palliative care should be recognized as an exercise in prevention of the ultimate sufferings, both in the form of physical symptoms and of psychosocial and spiritual concerns at the earliest possible moment. The proportion requiring palliative care is at least 80% worldwide, and most cancers are diagnosed when already advanced and incurable. Care of the dying extends beyond pain and symptom relief. With limited resources, it is not logical to provide expensive therapies benefiting only a few patients, while the majority of the patients with advanced disease suffer without any relief. Education in pain relief and palliative care must be essential for all healthcare workers who may be expected to treat patients with advanced chronic illness. Implementation of pain relief and palliative care measures would have a major impact on the quality of life of the patients. Each WHO member state has a responsibility to ensure that the health workers are adequately trained in cancer pain relief as well as palliative care, ensure the availability of opioid and non-opioid and adjuvant analgesics, particularly oral morphine. Relief from cancer pain can be achieved in almost 90% of the patients. Obstacles in pain relief in cancer are insufficient availability of opioid drugs because of regulatory and pricing obstacles, ignorance as well as false beliefs. A pain relief program should be established within the broader palliative care program. Unrelieved pain in cancer patients is unacceptable because it is generally avoidable. Freedom from pain must be regarded as a human rights issue. Problem can be addressed using inexpensive drugs. A 10 milligram of oral morphine tablet costs only ₹2, while its non-availability is causing tremendous pain in plenty of patients. The WHO pain relief program calls for increased public awareness that pain is always controllable. Incorporation of cancer pain management should be there in the trainings of doctors and nurses. Treatment of cancer pain should be available even in general hospitals, health centers and at home also. In case of psychological support, good communication is very important. So, information must be given with honesty, sensitivity, compassion and with adequate emotional support. Usually in many parts of the world, information is withheld from the patient. Information about what? The disease they are suffering from, their prognosis, that is usually not told to the patients. It may be impossible to cure. However, it is always possible to give pain relief, psychosocial support, improved quality of life as well as comfort in time. We have to involve the family, as families may have little knowledge about the disease and its prognosis, may have no expectations of pain relief, or they may be having very high expectations of cancer treatment. So, we have to involve them in decision making with regard to the treatment, explain the treatments in such a way that either they can give informed consent or they can even refuse the treatment. So, what are the priority actions? Implement the programs for improving the quality of life of the majority of the patients as well as their families. Programs to include pain relief, other symptom control, and psychosocial and spiritual support. Awareness that cancer pain can be avoided, and we should ensure the availability of oral morphine. Opioids are classified as narcotic drugs due to potential of abuse, regulated by international treaties and national drug control policies. There are exaggerated fears of addictions, and pain relief often has very low priority. These are the difficulties in palliative care. Thought for us, Cancer Aid Society, which has pioneered in organizing palliative care workshops across the country, has given us this thought. Even the hardcore criminals who are sentenced to death are asked for their last wish, which is fulfilled, and they are given a painless death. It is indeed very unfortunate that the patients who get a death warrant by cancer suffer for months together in excruciating pain, cursing themselves for none of the sins they have committed. Should they not be given freedom from acute pain as they pray for an early death to get rid of the pain? Yes, they can, says WHO, by giving oral morphine. Then why do they suffer from agonizing pain? As even today, oral morphine is not readily available across the country in spite of simplification of NDPS Act. Thank you.